Okay, and we are recording. And I'm delighted to have with me today Dr. Ali Ibrahim, who is training in child and adolescent psychiatry in London with an interest in eating disorders, and Dr. Agnes Ayton, who's a consultant psychiatrist in eating disorders in Oxford. Welcome.
Hello, thank you for having us.
Thank you very much.
Yeah, you're very welcome. I really appreciate you coming on. I first saw you, Agnes, on Twitter, and I've been following your research very closely. And recently, you and Ali published a review called "The Western Diet: A Blind Spot of Eating Disorder Research," and it basically says that over the last 50 years, in parallel with the obesity epidemic, the prevalence of eating disorders has increased and presentations have changed. So Ali, maybe you could talk a bit about that and maybe say how much worse the problem is now than it used to be.
Yeah, thanks very much, Ali, and thanks very much for having me on. It's a real honor to be here and talk to you. I think you ask a really important question in terms of the way eating disorders have changed, and I think it's really important to talk about that in a lot more detail. But just to start off with, let me just, I think times have changed, and I think, the way that we're eating has changed, but lifestyles have also changed. And it's really good to see that in a lot of disciplines within medicine, we're starting to address dietary and lifestyle factors, a really positive move. And unfortunately, in eating disorders, we're way behind the curve right now. So, but there's, just before we kind of launch into how things have changed over time, I just want to dispel a couple of myths, right? Because a lot of people ask questions about eating disorders and how that might relate to changing one's diet and lifestyle, and triggers and risks thereof. And I think it's really important to address a couple of things. So number one would be the problem that people often bring up, which is variety in one's food, and the fact that increasing variety indicates treatment of an eating disorder. Restricted variety can be a risk for developing an eating disorder, and how much variety should we include in diet. And I think it's really important just to say that from my point of view, and I know it's a very contentious issue, particularly in eating disorder circles, but variety really is about nutrition rather than type of food. So I just need to emphasize that. So variety is about nutrition that we're including rather than type of food. It's a really important point, because if we look at type of food, the types of food that we have in the Western diet at the moment are basically a cocktail of exactly the same ingredients mixed in, different creative ways. So it's a variation of a grain together with processed seed oil, sugar, salt, mixed together with flavorings and preservatives in very creative ways, packaged and sold as different types of food. And so if we're talking about types of food, which is often the thing that is spoken about in eating disorder circles, that if you increase the variety in your diet, it's a good thing. Actually, it's quite a restricted diet. You say you've got 4 or 5 different ingredients that have been mixed in different ways. So that's the first point. And if you're having a relatively quote unquote restricted type of variety in terms of type of foods, but nutritionally complete, that isn't necessarily problematic in terms of developing an eating disorder, or indicating relapse within eating disorders. And I think so that's the first thing. The second thing is in terms of frequency. So often it's sold in eating disorder circles, and people ask about how often should one eat, and frequency being something that's promoted by eating disorder professionals quite often. I think that's something that we just need to put out there and say that frequency, it doesn't necessarily indicate that you've gotten better, and frequency isn't necessarily something that's needed in terms of a good, adequate, complete diet. And then the last thing I just want to briefly touch on real quick is the difference between fasting and starvation. And that's something that's often confused. And I think that a lot of people at the moment are wanting answers about, particularly with, people adopting low carb and fasting. And I think they're really powerful things, but we just need to differentiate between the concept of what starvation is, which is extreme, restriction in terms of nutrients, where one then ends up being malnourished. And that's very different from a healthy way of eating, which is organizing one's meals into definite periods of eating and then not eating. And those are very different concepts, and often they get mixed up. And actually if we use them in the correct way, it can actually be a very powerful intervention. And I think even within eating disorders, using something like periodic eating, because I think that's probably a more accurate term to use, instead of fasting, because it's a normal state of affairs to eat at meal times and not in between. Unfortunately, in eating disorder circles, that's something that often we promote snacking, and that can make things worse. So eating periodically can actually give patients with eating disorders more control over their eating. And I think that's a positive thing if used correctly with the right level of guidance and coaching. So does that make sense? I just thought those three things
Absolutely.
are really important, just to dispel myths, particularly at times where we're seeing a lot of positive change.
Sure, yeah, it really does. And it kind of anticipates some of the questions I was going to ask later on. I've tried to be as, respectful as I can online when I'm talking to people, because I think, you don't get anywhere by getting people's backs up. You really only make people on sort of quote unquote your side back you up, and it doesn't really get you anywhere in terms of continuing understanding. And what I've seen, and I haven't really had much answer to because I don't know much about it, is people saying that to recommend a so-called restricted diet is inherently dangerous when it comes to eating disorders, which obviously you're saying it's more about the nutritional profile rather than the number of ingredients per se, which is really interesting to hear. And that there's important distinctions to be made around that. That's really interesting.
Yeah, absolutely. I completely agree with you in terms of not getting not opposing people, and I think it's best that there's dialogue with these things, because ultimately we're trying to get answers. We're trying to ask good questions, get good answers, and actually help people. So that's that's really where we're at. But in terms of restriction and where we stand in in how and when we define what constitutes an eating disorder, I think that's a really important distinction to make. Is it that you're restricting in a way that indicates that you're developing a disorder? And I think the question here is one fundamental question, which is what is your level of functioning? How are you feeling in yourself? And quite often when you're having a nutritionally complete diet, you're feeling a lot better.
Can I just come in here? I was just sort of thinking about your question, Ali, and you were asking how things changed over time. And I think it's quite important to think about that, because historically eating disorders were kind of very much focusing on a very small proportion of people suffering from anorexia. And over the last, I would say kind of 40, 50 years, we have seen a change of eating disorder presentation. So obviously one of the prominent people who was open about her bulimia nervosa was the late Princess Diana, and a number of kind of celebrities have opened up about having bulimia. And over the last 20 years, there has been a lot more awareness and increasing rates of binge eating disorders. So actually, eating disorders affect a lot of people, and I think it's best to look at eating disorders as a spectrum. If we kind of look at international epidemiological data, then overall the estimation is about 6% of the population who has a diagnosed eating disorder. But I think in addition to that, a lot of people are struggling with disordered eating. So we should be kind of looking at it as more of a kind of a spectrum that even if people don't have a diagnosed eating disorder, they might have disordered eating. And in our work, when we kind of try to review the literature, we were looking at actually what are the parallels, what has changed over the last 50 years that might contribute to this almost kind of explosion of disordered eating and the really changing kind of presentation. And looking at the potential reasons, one thing that has really changed over the last 50 years is the food environment. And that's why we ended up kind of looking at how the food actually itself can drive disordered eating in the population, and then what is the implication in terms of treatment.
Yeah, that makes sense.
Yeah.
I was going to ask, is there much evidence that eating disorders existed before 1900 or so?
There were a few descriptions. I mean, the very early description was in 1689 by an English physician, and that was about anorexia nervosa. So kind of, although they didn't use the term until the 19th century. And in the 19th century, there were some descriptions, but it was not, so bulimia nervosa wasn't really described until the late 1970s. And so the restrictive eating disorders are probably least common, and yes, they have changed, but the bulimia and the binge eating disorder seem to have exploded actually. And there are very few studies looking at the parallels between disordered eating and eating disorders, but a lot more studies looking at disordered eating and obesity. So there was one study from Australia when they found actually the trends of disordered eating are going up in parallel with obesity. But there have been a lot of studies looking at, well, actually with the obesity epidemic, a lot more people are dieting. And then, of course, the dieting, again, what kind of food choices people make, and how does that actually drive the whole pathology, both the behavioral problems and the psychological problems attached to eating disorders.
So there's a complicated kind of web of cause and effect here that's hard to unpick, especially with epidemiological sort of associational population level data. Evidence of eating disorders before 1900, and it kind of leads me into another part of the review, which says that you really try to make sense of human behavior in light of evolution, and maybe one of you can talk us through how eating disorders might arise from our evolutionary adaptations, and whether this is different for men and women, and whether this is, it's always the case that there's an evolutionary adaptation at play, or whether there's sort of competing interests.
Well, I think that's a very interesting question. One of my highly regarded colleagues, Riyad Abed, developed intersexual competition hypothesis of eating disorders. And he was basically interested in sexual selection. And I suppose it's well documented that in terms of mate preferences, men use a lot of visual cues when they are choosing a partner. They obviously value youth and the kind of sign of nubility, which means kind of a narrow waist and a youthful kind of slender appearance. And in his sort of hypothesis, he has been looking at, well, actually, how does that impact on women competing with each other? And then competing with each other is quite central to eating disorders, and it's not very well actually explored in eating disorder treatment, but we do see that in clinical practice. And you also see that not just on inpatient setting, but you also see it on social media. So women kind of exposing and showing their bodies and kind of comparing themselves with others and trying to achieve a kind of a perfection. And I suppose what he was saying, that there is a kind of an evolutionary mismatch, because we are living in an obesogenic environment, and actually the time of reproduction has been delayed. So women are not getting married in Western society until maybe late 20s or 30s. So they need to kind of maintain that very slender, useful figure for the optimal kind of mate preferences, and that drives the dieting behavior. And I think there is we found some evidence kind of linking in this observation with an epidemiological study from the Netherlands, when they were looking at actually dieting behaviors across the population. And it was really interesting that women of younger age, so 16 to 25, were the most worried about getting overweight or gaining weight, and they were dieting most, as opposed to men were dieting a lot later in life when they were actually gaining weight. So that was sort of quite an interesting observation. I mean, in addition to the intersexual competition theory, there are other important evolutionary kind of thoughts with regard to metabolic responses to food. So one of the things that has really changed in the modern food environment is the lack of seasonality. Until really, I would say probably 100 years or even less, longer, or maybe last 50 years, food was always seasonal. So you wouldn't be having fruit for a short period of time. In the summer, you would be having a more kind of animal source foods in the winter, and particularly in sort of higher latitudes. The summer periods were quite short. So all of a sudden, in a modern food environment, we have an eternal kind of an eternal summer when we are having a kind of large amount of carbohydrates and fats actually together, which is not something that would have happened in nature, and therefore our metabolism is not really kind of prepared for that. So for example, if you kind of think about other animals who hibernate or prepare for the winter, there is an excess eating of fruit or nuts together in late summer or autumn, and that triggers an anabolic response, and then and it's a number of species kind of gaining weight before the winter, and then during the winter, obviously those foods are not available, so the metabolism changes during the seasons. And I think we have lost that. So we are in a constant late summer, early autumn kind of anabolic state, which kind of makes people prone to weight gain and disordered eating.
Yeah, and you make a point in the review of mentioning omega-6 to omega-3 fat ratio. Um, you mentioned in the review about the negative effect that too much linoleic acid can have on the gut health, microbiome health. Do you think there's other pathways there that are involved? I mean, I know that I've seen research that shows that excess linoleic acid or even linoleic acid triggers the cannabinoid pathway, so you effectively get the munchies. So you want to eat carbohydrates when you eat linoleic acid, which sounds similar to what you're talking about, which is a direct route to, certainly gaining weight, but maybe in the longer term metabolic problems. What do you think about all that? How much blame do you think can be laid at vegetable oils, for example?
Well, I think in terms of nutrition, we ignore our evolutionary history and our metabolism at our peril. So kind of raising the issues about omega-6 oils like soy oil or corn oil, etc. These foods weren't available in the human diet until again, it's probably 100 years ago. So our metabolism is not adapted to that, and there are multiple mechanisms why these omega-6 fatty acids could be harmful in excess. Obviously, they are necessary in a small amount, but they are pro-inflammatory. They influence the microbiome, and they influence kind of multiple neuroendocrine pathways. So I think it is really quite important to take that seriously and use natural fats which are not made in a factory if you want to retain your health.
Can I also just pick up on that and say that there's two important things that you're trying to do here because we're talking about a really vulnerable group of patients. If in eating disorders you're dealing with patients who are massively underweight, malnourished, and you're trying to refeed them, and when thinking about that, one should consider that you're essentially rebuilding them. So what you feed them is really important, and I think the argument of what to eat, just merely talking about it is actually really important, because I think in eating disorder at the moment, most therapies don't consider and actively discourage discussion of food type. So just I think being mindful of it is a massive first step, and having that discussion with patients, with families is really important. But the two things that are important is excluding things that might be irritants. So when we're talking about vegetable oils and things that can be pro-inflammatory and how that affects the gut, we know that a lot of people with eating disorders actually do have symptoms associated with the gastrointestinal tract. And so removing irritants is really important, but then the other aspect of it is actually refeeding them the right thing that that's going to rebuild them from a nutritional point of view as they're putting on weight. And likewise, patients with eating disorders that are overweight, that are either bulimic or binge eaters, feeding them the right type of food in order to heal is really important. And I think starting to have that discussion in eating disorders is really important.
Do you think that there's a danger in someone who has some sort of disordered eating in asking them to categorize foods as better or worse?
Yeah, I absolutely love that question, Ali. I mean, look, it's the one thing that is often a problem, okay, and it's the one thing that's actually ignored, and that's the problem. Patients come to us ordinarily in eating disorder services with, by the time they've gotten to you, they've had an eating disorder for multiple years, they've struggled with it massively, and they're wanting answers. And the one thing that they're wanting answers about is, what do I eat? you know, they've often gone through multiple, you know, trials of different types of foods. They've failed multiple times. And actually, you know, so there's two aspects to this. If an anorexic is coming to you saying, you know, what do I eat? And that's a really good thing. Most of the time, anorexics don't present to services. And then, you know, if you're dealing with somebody who's binge eating or a bulimic and who's asking that question, it would be completely criminal of a professional to ignore that, because it's the one thing that, you know, they've come to you after, you know, a lot of struggle, a lot of time, and then you're ignoring the one concern they have. So that immediately would disengage them from therapy. I think it's really important to address that question and be open with them. And there's often things, you know, exploring things in an open way with a patient brings stuff up in terms of, you know, what they may have tried before, and that's an opportunity for us to talk about and educate patients about, you know, lifestyle, about nutrition and diet, and it's a discussion that they've never had before. And it's an opportunity to stabilize things, for, you know, so that which is one aspect. But the other thing is that, you know, you want them on board. You know, they've come to see you, so you want them engaged with therapy, and a therapist will lose a patient that doesn't address the one thing that's important to them. And food type is absolutely fundamental to most people that are presenting services. But I mean, so back to the question about, you know, changing the changing food environment, and just to elaborate a little bit more about Agnes's point that there's a whole spectrum of disordered eating. And I think it's really important to emphasize the point that what we're seeing in eating disorder services is that the absolute tip of an iceberg. And as times have changed and if the food environment has changed, we've got a whole range of disordered eating, which has led to a lot of the physical conditions that we're seeing nowadays. And people, it's absolutely brilliant that we're seeing a lot of change and that people are trying to address that. But there's this problem of, you know, at the beginning you will struggle, and there's probably multiple failures that one goes through because of the number of years that you've been subjected to, you know, a diet that's less than adequate, and actually addressing the underlying psychology to what may have led to disordered eating is really, really important. So it's just that there's this idea that, you know, eating disorders are a niche kind of, you know, area, and I don't think that's the case at all. I think eating disorders is relevant to absolutely every branch of medicine. It's, you know, it's the knowledge of and the psychology of disordered eating is a massively powerful tool to be helping a lot of people that have gotten themselves into problems.
I also would like to add that actually there is increasing research evidence emerging that ultra-processed foods are harmful for the majority of the population, starting really from kind of infants and children. So we we're kind of discussing the novel food classifications. I don't know whether you've come across this, Ali.
Yeah, so it's a classification of how processed a food is, and it's an attempt to make a really kind of more rigid classification, because obviously there's an issue with calling a food processed in a negative sense, because you could go to a Michelin-starred restaurant and the food might have been prepared by 4 chefs, each making their own contribution with extremely complicated processes. So that's processed food. But those ingredients are likely to be whole food ingredients. And similarly to what Ali was saying earlier, you know, in terms of variety, if your variety exists in terms of 10 different types of refined flours, then that's hardly a low processed food diet.
Yeah, so it is about industrial processing, and there's increasing research looking into this, both from a kind of a epidemiological point of view, how the ultra-processed foods are linking with various diseases like cancer, heart disease, diabetes, etc. And it does seem that they are harmful. But then also there have been some very interesting research looking actually the effect of ultra-processed foods on the brain, the reward circuits of the brain. And that actually can give us some understanding and explanations why these ultra-processed foods can trigger abnormal eating. And the mechanisms are quite complex. It's very interesting. I mean, in our review, we found, for example, I mean, obviously it's well known that ultra-processed foods are high in sugars and omega-6 kind of vegetable oils, and even trans fats. So trans fats haven't been completely removed from the diet, even though that there is very clear kind of recognition that they can cause heart disease. So that's the problem with the ultra-processed foods, that they have multiple chemical ingredients, which again wouldn't be part of the normal cooking food preparation processes. It's very interesting. So for example, a lot of our patients, regardless of the type of eating disorders, use diet products. And then the diet products have things like emulsifiers in them, because if you remove the fat from, for example, a low-fat yogurt, then the consistency wouldn't be very attractive. So the food manufacturers put emulsifiers in there. The emulsifiers actually damage the gut lining, and they can cause inflammation. And it is highly relevant to our patient population, as Ali was saying, that a lot of patients with anorexia have gastrointestinal problems, irritable bowel syndrome, etc., etc. And they are actually eating these diet products in an attempt to kind of control their weight, being totally unaware of the effect of these diet products on their bodies and on their health. And in terms of actually the other issues about the diet products, that quite often the manufacturers use a combination of natural sugars and artificial sweeteners. And there was just a study just published very recently when they were actually looking at how the brain responds to the sweet taste and kind of glucose metabolism if that combination occurs. And it seems that the brain can kind of distinguish glucose. Obviously has the insulin response and the metabolic pathway, which is long kind of been in human biology. But if you combine artificial sweeteners with glucose drink, then it totally confuses your appetite, your nutrient sensing in the brain. It also increases insulin resistance very rapidly, increases insulin response. And again, this is really new research, so patients and maybe even the field is not really aware of it, that the ultra-processed foods are not metabolically inert. And that is one of the things that I think the field needs to take kind of more attention to. And you were kind of saying that there's a concern that, for example, if somebody has obesity or type 2 diabetes, if they go on a low-carb diet, whether they will develop an eating disorder. I haven't seen any evidence of that happening, but I know that this is a common concern, and I'm sort of thinking, well, actually, if you remove things that are metabolically harmful, then the chances are you developing an eating disorders probably will go down rather than going up.
Yeah, that's interesting. I mean, you know, it seems to keep coming back to this recommendation to at least talk about removing the worst offenders, to give eating disorder people with eating disorders a better chance. But I mean, with any mental health problem, there's multiple potential causes, right? So, I mean, with any mental health problem, it might be past trauma, it might be food industry marketing, it might be some sort of social coercion. I mean, how do you see the causes breaking down in terms of prevalence?
I suppose that's why we were interested in the prevalence data. So when we're talking about an increased rate of eating disorders in parallel with the obesity epidemic, then it would be highly unlikely that the level of trauma would increase at the same time, the same 50 years. And I suppose what we were kind of trying to highlight, that current psychological treatment do address the psychological issues, and they do kind of consider family factors, etc. And what we are kind of trying to say, well, actually, we should include the individual metabolic responses to food. So we shouldn't forget about that. Because again, there seems to be that if people kind of have a more stable, for example, glucose regulation by changing their diet, then they experience an improvement in their mental health. Because the brain is actually responsive to the chemical environment in the body, and the food is the chemical environment. We kind of can change on a day-to-day basis. So I think that is something that we need to pay a lot more attention to.
Yeah, it's like Georgia Ede says, studies have shown conclusively that the head is part of the body.
Yes, definitely. And that has been a problem actually particularly in eating disorder research. Because all the research looking at metabolic disorders, diabetes, obesity, is going on in a acute kind of physical side, and there is very little crosstalk with eating disorders. So eating disorders tend to look at the psychological factors. I wanted to mention that there was a very interesting example in Fiji. So Fiji is obviously a Pacific island, which until recently had a traditional society with traditional kind of seasonal food, fish, fruit and vegetables. And they kind of introduced US type foods very rapidly, I think over the last 40 years. And there was a very interesting study led by Becker looking at the increased rate of bulimia in particular and binge eating disorders in Fiji. And she was looking at the American cultural influence. So she was interested in, well, how do the girls in Fiji get influenced by the thin body images of Hollywood actresses on television. And at the same time, there was a transformation of the food environment with American adverts of processed foods, changing the diet, and the massive explosion of obesity and metabolic disorders and diabetes in Fiji. And it's quite interesting that these two research kind of streams were working in parallel. And as you said, brain is part of the body. So actually, it could be the two sides of the same coin.
Can I just add to that? You know, I think and correct me if I'm wrong here, Agnes, but in terms of the it's a very interesting example of Fiji. But I think the point that we originally missed with a lot of the research in this example is that it's the food environment that's changed, and I think a lot of research considered the social aspects and emphasized that, and that's often what happens particularly in eating disorder research. Where we're missing the fact that the food environment is changing, not just there's westernization, and and that's really important, both from a research point of view, but also in terms of us understanding underlying factors.
Yeah, and part of the problem perhaps is that you have two competing theories which kind of started around the same time. So, the kind of depiction in magazines and television of physical types kind of is a 20th century phenomenon, as is the changing food environment. And when you have population level data, it's difficult to extract which one is giving you the biggest signal, perhaps.
I think that is a fair point, and certainly I think even sort of 20 years ago, in eating disorder research, there was a lot of discussion around how much is the kind of media driving, particularly anorexia and dieting, and maybe it does contribute. But I think when we're thinking about media driving this, at the same time, the population has been getting fatter. So as much as we are bombarded with thin images, when people are actually eating, and particularly people with eating disorders like bulimia or binge eating disorder, they're talking about being unable to control their eating. And that is kind of quite a separate process from looking at an image and wanting to be like that. So the uncontrollable nature of eating disorders, which arose over the last 40, 50 years with bulimia and binge eating disorders, I think it's
Agnes as well, associated, sorry to interrupt, but associated with that, there's that stark contrast of, what is depicted in media and, what people actually see in terms of the obesity rising in real terms. And I think particularly with the eating disorder population, there's a lot of people that are wanting to avoid that situation of, metabolic syndrome. They're aware of this, they're aware of, obesity being a risk, and they're wanting to address that without having the knowledge of how, and this is why I guess it's an opportunity, that but instead, the way that they're what we recommend in terms of feeding these patients is highly processed diets, which basically makes matters worse, I guess, when they start treatment, which we can come back to. But I think there's that stark contrast that people they're exposed to images. But also they're very much acutely aware of obesity being a risk, and they're wanting actively to avoid that. And in some ways, these patients with eating disorders, when things start, are people that have identified a problem, that are trying to address it. They're just doing it initially in maybe the wrong way, or in ways that haven't been completely informed. And again, back to this, the image of the iceberg. I think there's so much to be done in terms of preventative care to avoid people getting to the position where they're, having to treat a fully fledged eating disorder. I think in the earlier stages, particularly with children, if we're educating them about nutrition, eating what actually is, adequate, good nutrition, and helping them avoid the problems that they're seeing around them. I think it's a really powerful intervention. It can avoid a lot of problems further on.
And
yes, and again,
sorry, on you go, Agnes.
There was a study actually looking at the preventative benefits of having a Mediterranean diet with high olive oil. So that would be kind of natural unprocessed foods with high level of olive oil actually found that there was a reduced risk of eating disorders developing. So, and in our own clinical sample, we looked at what kind of foods people binge on, and what patients report. It's a very preliminary study, but what we found that people binge on 100% on ultra-processed foods. So that would be things like ice cream, cookies, pizza, etc. What actually comes out of a factory, and I think that's sort of quite an important point, because food does influence how the brain senses satiety. So natural foods, for example, if I kind of give this example, if you have something like mackerel, you can't really overeat that, because your brain will sense the nutrients and you feel full. Whilst if you have something like a combination of fats and sugars, and this has been shown in brain imaging studies, then that kind of stop signal is not working well in the brain.
It's that so-called bliss point, which McDonald's uses so well. And I told you before the show, I'm developing a sugar-free ice cream, and I think for some people it could act as a trigger, but for other people it could be a great way to get away from something that actually has sugar in it. And it's a debate that keeps kind of raging on. But nobody's binging on lamb chops.
No, nobody binges on mackerel, that's for sure. Yes. and I suppose that's just a direct illustration of the brain's response to food, and then and it's really quite interesting to see that in children and young people. And you can also see the difference between children who are breastfed and people who are children who are formula fed. So if you see formula fed babies, they tend to be a lot larger than breastfed babies, and it is about the nutrients that the breastfed babies actually stop eating before they get overweight, and that is kind of quite a scary thought, actually.
Because but also just to add to that point, Agnes, with formula, it imprints those distortions in a child from a very early age, where they would later on in life select certain foods. So you're almost from an early age, we're rearing a whole population based on what they're being fed early on, and that, I guess, it increases a number of different risks, including eating disorders. But if you're eating in disordered ways because of how you were fed earlier on, it serves whose interests other than people selling these products. So
this is something that I've spoken to people about before online, and it's again a very sensitive issue, because sometimes you have parents who have had no sleep for weeks, and health visitors coming round going, oh, the baby's lost 10% of their body weight and they need to eat. So they feel like they've got no choice, because maybe the baby's tongue-tied, or they didn't for some reason take very well to breast milk. So they give them the bottle and they feel terrible either way.
Yeah, there's always problems with this. I mean, it's obviously if there is a problem, then you address the factor. I think there's it's probably beyond the scope of this discussion in terms of breastfeeding and
that's fair,
and how to address problems of breastfeeding. But we can go into that maybe a different time. But I think this is a whole separate discussion, and I think it's possible. I don't know what you think about this, Agnes, but I think it's possible to address a lot of issues with breastfeeding. And I think, where it's needed and where it's absolutely necessary, we have a powerful intervention that can be used if it's needed in extreme circumstances. And I think that's a really good thing.
I suppose it's important that in our model, we were trying to integrate the psychological and the metabolic and the physiological aspects. So I think it is entirely possible. Um, uh, because, you know, for example, the current leading psychological model, cognitive behavioral therapy, is interested in the maintaining factors of eating disorders. And obviously, you know, we're not saying the psychological factors are not important, but we are saying that in addition to the psychological factors, we need to pay attention to the metabolic and neurobiological effects of food, which is actually potentially driving the disordered eating and a lack of control.
Yeah, I think that's a fair point. Do you have anything to say, kind of to summarize, Ali?
Yeah, no, I think it's so at the moment, let's think about what it is that we're actually doing in eating disorders in terms of, you know, the therapies, right? So there's two main treatments. For adolescents, it's mainly family therapy, which I think is a really powerful intervention. I think it's really good that you're bringing the whole family and thinking about the system in its totality. But I think there's other aspects that are part of that system which are potentially overlooked, like, you know, societal influences, the industry, of course, and, you know, government guidelines, and how that might be influencing how young people are thinking about their diet and what they're doing. So that's one main intervention that's used, and the other is cognitive behavioral therapy, and it's used for the older kids or in adults. And again, I think it's a really powerful, it's a really useful intervention. But, you know, Agnes' point is definitely valid, that, you know, it doesn't, you know, that's the whole point of the paper, that it doesn't include the biological aspects and the metabolic influences, and that's very much orchestrated by the type of food that you're eating. And I think there's this problem that we're overlooking in the eating disorder world, which is that over time, although these therapies are really quite useful, we haven't really shifted forward over the years in terms of the number of, you know, in terms of outcomes. So overall outcomes, if we're looking at all therapies at the moment, you know, cure, I guess it depends on how you define cure, but we're not achieving beyond, you know, 30 to 40% of patients actually resolving their eating disorders. And I think that shows that we're missing some fundamental aspects. And those are the things that we touch on in the paper. But if we look at, I guess if we just take a bird's eye view of what actually is done in those two main therapies and other therapies that are used in eating disorders, it's essentially fourfold, right? So you're giving them psychological support, and that involves weekly sessions initially for some patients with anorexia. It's twice weekly sessions, and you taper that off, you know, as time goes on. So that's the first thing that you're giving them. Then, you know, you're giving them a weight chart and you're monitoring their weight. Number two. Number three, you're giving them a food diary and you're monitoring what they're doing. And then the fourth thing is a meal plan. But there's things that are missing. So, for example, when patients are monitoring what they're eating, the food diary, they include the type of food that they're having, the time of day, what emotions might be associated, whether or not it was associated with a compensatory type behavior, so whether they make themselves sick or compelled to overexercise at the time or something of the sort. But what might be useful to add on to that, to a more picture of happening and inform, you know, to work collaboratively with the patient, is the biological aspect. So having another part of that food journal to include, very simple, you know, something as simple as a blood sugar can be quite informative, you know, both for patients that are recording this and the professional that's working with them. But then also in terms of, you know, so the fourth part of, you know, what I said was what we do is, you know, the meal plan, and what often is promoted as good is having, so we don't consider food type, so it's just having a broad range of different types and something or if I'm wrong, but there's not a lot of them to, and so really taking into account the the biological metabolic aspects of what's included on that meal plan.
I lost you a little bit there when you came off.
Oh, apologies, Ali. Yeah, so I was saying that
the last bit about the meal plan and how you don't tend to assess the specific types of foods.
Yeah, so there's the meal plan that's used, I guess, is a fundamental part of the treatment. And often what happens is it's given to patients either as part of cognitive behavioral therapy or family therapy to the family, and it's sold as almost a prescription. If it were a prescription, then you're giving somebody something that isn't evidence-based, because the foods that are included on there and add to that, and then whether or there's for the individual patient and the metabolic effects of those particular foods. So I think that's really important.
Yeah, that makes sense. Well, I really appreciate you both.
Comments about the evidence for.
Oh, sorry, I kind of lost you a little bit again there. I was just kind of saying that that all makes sense what you're saying, and I really appreciate you both taking the time to articulate, some of the points around the review paper and the kind of extra nuances that come out when someone like me, who's very interested in this area but doesn't have any direct experience of it, kind of reads about that sort of thing. So I really appreciate you taking the time, and maybe you can suggest where people can find out more about what you're doing, each of you, and where they can, where you want them to look online.
I suppose I am quite active on Twitter, and I tend to kind of retweet relevant research papers. So if people are interested and are looking at new developments, then I tend to retweet them. And I suppose we're kind of trying to develop some further research in this area, but that takes time. So watch the space, I suppose. That's what I'm saying.
Okay.
Yeah, and Ali, thank you very much for having me on. And it's it's been a real pleasure. In terms of contacting, I can leave direct contact details for myself. Happy to be contacted directly. Not on any social media at the moment, unfortunately. Likely to change in the future.
Okay, cool. All right. Well, again, really appreciate it, and we have a great day.
All right. Thank you. Good luck.
Thank you.